I actually thought of waiting a bit, but then let's just start. Okay, guys. I'll be recording this class so that if there is anyone else who has missed or wants to redo, can actually get these classes online. Secondly, Happy New Year to all of you all. I hope 2021 is much better than the year that we've had. Hoping that we actually combat COVID-21, I mean COVID-19 well enough so that we can start living a normal life, right? Another very important thing I want to actually mention is that some of y'all actually complain. I mean, not some of y'all had issues with regard to the MS Teams. So I just want a, general consensus. If all of y'all feel that MS Teams is uncomfortable or the voice quality is bad, right? Just send a message to your counselor. So even if it is okay, you don't have any problems, please send a message to your counselor saying I don't have any problem. But if you feel that MS Teams is a little disruptive and you can't hear properly, if there is any of that sort, like someone had mentioned that whenever someone joins, it automatically the presentation starts reloading. So if there is any issues of that sort, just mention it to your counselors. Some of y'all have, which is good, which is really good, because feedback is very, very important, right? It's very, very important feedback. And I will actually tell you all about feedback with regard to medicine as well when we discuss about ethics in medicine. So it's good that y'all are giving the feedbacks, but I want to know after this class whether you all feel the same way. If you all feel the same way, please send a message to your counselors and they will decide if we need to change the portal that we use to deliver these classes. All right. That being said, right, let's look at the questions that we discussed last time, right? And I had actually given you all a question. So I want every particular time that we do, right? Every particular time that we I mean, the questions, each question, I want one of you all to answer, right? So, can someone start? I will share the presentation. Who wants to be lucky number one on on an early morning on Sunday? What's question number one? Okay, should I read the question and then someone will answer? All right. Right. What is the definition of first aid? Who wants to answer? No
It's the
volunteers?
help. Uh,
Very good. Go on.
it's the help given to a sick or injured person before until full medical treatment is available.
Okay, help given to a individual before
Is
medical.
sick or injured.
Yeah. So one thing is health, urgent help or emergency help given. Because you as a not a health professional, I mean, you can consider yourself a health professional if you're a first aider, right? So why? I mean, first aid is something that you need to give as soon as possible. That is why it says first. The first thing, as soon as you see it, how you can provide that help, right? So that's one. It is urgent, right? You need to do it as soon as possible until someone else who is more suited for this purpose comes and takes over from you. So the thing is this: you don't have to give medical help. It can be something non medical as well, like basically calling for help, right? Like for example, giving a call to 1990 and telling that there is a patient itself is first aid, right? So I hope you understand that. Right. What's the next question? The next question is, what are the three P's of a first aider? What are the three
Preserve
P's
life,
of a first aider? Okay,
preserve
very good.
life, prevent worsening, promote recovery.
Covered. Okay, can you just explain those three to me? How do you preserve life?
preserve life if the injured or the one who needs first aid is in a unsafe place, like in the middle of the road. We can get him or her to a safe place.
Okay.
And
So that comes in preserve life is basically making sure he stays alive, right? Making sure he stays alive. So for example, if someone has cardiac arrested, right, he has arrested, you start doing CPR. So that is preserving life, right? So you actually preserve his life. You make sure that you are increasing his chance of living, right? That is one. Second one, prevent worsening. Give examples. Just always, whenever you think of this, try to think of the examples. Okay, how can we preserve life? How do you prevent worsening?
if there's blood loss, we can like cover. We can tie a tight
Very
cloth.
good. Very good, very good. Because why? If there is excessive bleeding, he's going to go into hemorrhagic shock. His blood is going to completely go out, and his blood pressure is completely going to go down, and that is referred to as hemorrhagic. Hemorrhagic is bleeding. Hemorrhage is bleeding. Hemorrhage. 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 Right. So hemorrhage is bleeding. So if someone is actually bleeding from something, you can say he's hemorrhaging, right? So the lay term in normal talk, when we speak, we say he's bleeding, but actually he's hemorrhaging, right? So hemorrhaging can be internal hemorrhages and external hemorrhages. There can be bleeding from the outside, or there can be bleeding from the inside. So if there's a wound, then it's called an external hemorrhage. But for example, if he's bleeding from his gastrointestinal tract, for example, the stomach, if he's had gastritis and he's got a stomach ulcer, right, and that starts bleeding, then you actually call it is a gastric hemorrhage, and it's bleeding from it's an internal hemorrhage, right? So if by any chance, if there's any patient who is having any external hemorrhages, correctly like the way you said, right, if he keeps on bleeding, he's going to lose a lot of blood, and he might go into hemorrhagic shock, right? So hemorrhagic, as he has bled, he's going into shock. So because of that, right, you have to actually try to prevent that. So that is why you're preventing hemorrhagic shock by controlling the bleed. Understood?
Yes, doctor.
Right. Last one, promote recovery. How do you promote recovery?
By giving some medicine, uh, applying plasters.
Exactly. Good, good. Right. Super. Very good. Very good. I want you all, another thing for all of you all, I'll mention this over and over again, right? I know all of you all are going to go into medical school, right? Always remember, right? This is going to take you, this particular statement that I will tell you, you will maybe you all won't understand right now. But maybe in another few years when you're in medical school, or sometimes you might even not even realize it when you're in medical school, when you start working, you will realize how important it is, right? And that is trying to understand and sort of imagine things of how they work. That is going to be very useful when you go get into medical school, having sort of an approach where whenever you look at a point, you think about a particular example. As soon as you think of that example, it makes sense automatically. It gets registered into your memory. Don't just like, what are the three pieces? It is prevent. You just always think, okay, right, so if some first aid, it's an urgent thing where the person has to actually, you need to make sure the person is alive. So yeah, so you need to preserve his life. Like also it is to prevent a lot of other problems, the further problems that happen. So you prevent the worsening, right? And the last one is like, okay, make sure that he recovers soon. So promote recovery. So if you think of it like that, it's going to make more sense. Rather than by hearting these three P's, try to understand. Okay, and this, now I know this is not very essential, but the whole point of this class is so that I can change the way that you all look at medicine. I can change the way that you all will study when you are going to medical school. That is the reason that I'm doing this class. I am teaching you all about a lot of different things, but at the end of the day, I want you all to change the way that you all think. Believe me, your medical school life is going to be much easier if you start developing this ability. All right, right. What's the next question? The next question is, what is the emergency hotline ambulance service in Sri Lanka? I'm sure everyone knows that now. Or is there anyone in this class who doesn't know that? right? It is 1990. Okay, why is it important to remember this number? Anyone wants to? This is a different question. Why is it important to remember this number?
Because when there's an emergency, we are supposed to call this number first before even engaging with the person.
Okay, but why am I emphasizing? Why do you think that it's like, why is this doctor, for lies, I know this, yeah, it's there, but why am I, emphasizing so much? Does anyone know why?
Probably because you're more likely to call 911 rather than 1990.
Okay, but why? Anyone else have got any inputs? Why am I emphasizing so much? Okay, I'll ask you another question. Have you had anyone in your uh, close family who has needed help when you're there? Like someone just fainted and is now not, not breathing, not talking, and you're super confused as to what to do. So you all don't have anyone in your family or anyone that you've seen, who you know personally, who has had any medical emergencies that are needed? No?
Yes, doctor, I had.
Okay, so how was it? How was that feeling?
Like, I don't know how to explain that, doctor.
Exactly. So the thing is this, okay? Remember this. It has happened to me also, okay? I mean, when it's someone, it's a loved one, right? When it's someone like I'm like talking like you do this, you do that, and all of that. But emotions do play a big role, right? So sometimes you become very agitated, and sometimes peace. A lot of patients, a lot of relatives go into this phase where they like, in a sense, they just don't know what the hell is going on. They'll just try to think about, they're like just on the phone trying to call, and they're just just fudging that they can't make the call, and sometimes they don't even remember the number. And say, what's the number, even though they know it, they forget about it. So what I do is I actually emphasize on this, so that 1990 should be at the, like, it's just at the tip of your tongue, so you don't forget it, right? Because I also had an incident where my uncle, I was actually an intern in Balapitia. My uncle actually basically he had chest pain, and he had gone for a swim, and that had exacerbated it, right? And I was still an intern. I was at Balapitia at that time, and rather than calling 1990, my mom and my auntie called me, right? And I was like, stop calling me and quickly call 1990. But they were trying to call me for a long time. They were like, what the hell is going on? They didn't realize the urgency of it. Not that I'm saying that, I'm not going, because I don't want to relive it, but not that I want to say that if they had called and it would have made a big difference. But yes, medically speaking, it would have made a big difference. And maybe my uncle was alive today, right? So it's very important, because you calling 1990 early and make promptly calling them could definitely save lives, not just one, millions of lives, right? So always, the reason I emphasize this is so that it's at the tip of your tongue. So even if it is a loved one, even in a scenario where it's very, very difficult, where you have a lot of emotional stress, all of these stressful factors will not make you agitated in making the necessary decisions in calling this number. That is why I emphasize on this particular slide. Understood? Right? So it's very important, because only when you experience it firsthand, right, is when you will know that how it feels like to actually, be in that situation. All right. So that is the reason that I emphasize so much. Right. What's the next question? What are the 4 components of the survival chain? Right. Anyone wants to answer that? Everyone should take chances. Yeah, I want to finish this by, I want to finish this discussing these questions by 8:30 so that we can discuss the bleed, other first aid measures. Okay. No one wants to answer this? Now I'll have to start actually asking you like personally. Right. First aid survival chain is consisting of four particular features. One is early access, right? So that means getting help, calling for help as soon as possible. So you get early access to medical help. As soon as you see the patient, if the patient has arrested, you start CPR as soon as possible. If the patient needs a defibrillation, what is defibrillation? Can someone tell me what early defibrillation is? What is early defibrillation? So you're saying no one knows what defibrillation is? Not even one student here?
Basically, when they're having cardiac arrest and the heart stops beating, we use a defibrillator to get the person back. It's like
Okay. I'll
another
teach
way
you
of.
something. I'll teach you. No, it's not that. I'll teach you something very advanced, right? Don't do. It's a very advanced thing, but let's see if you can follow. All right. Right. So hold on. Right. Okay. How do you get this big? Okay. Now, have you all seen an ECG machine? Have you all seen? I'm sure you all have seen these graphs, no, where where there is a beat, right? So this is the normal pattern, right? This is the normal pattern of a beating heart. Okay, right? So it just beats. So this is one beat, second beat, third beat. This is a normal heart with a heart rate of around 60 beats per minute. You all have seen, no? So how do you know in movies and all? How do they say the person has died? There is no beats. It goes in a straight line. Correct, no? So you call it. Is basically some people call it flat line, right? Some people call it asystole. That means there is no heart activity. That is why there is no electrical access. There is no electrical activity. Therefore, you don't get these registered beats, right? So a person who is having asystole, like what you said, you can't give defibrillator. You just have to do CPR. That is, CPR. That is cardiopulmonary resuscitation. You do cardiac massage and give him ambu ventilation. But there are some, okay, there are some you will see who don't get flatline. They have arrested. That means they don't have a pulse. They're not breathing properly. What happens to them is their rhythm is like this, right? This is actually called ventricular fibrillation, right? Not important to know, right? So they are beating like this. It's just like pisu wagi heart is just contracting. There is no blood that is going out. It's just vaguely contracting. So it's equivalent to not blood not being pumped up, but there is something like this. So for people who actually have this sort of rhythm, right? You need to defibrillate. You need to actually restart the heart. You need to actually shock it. So shocking is called defibrillation. So you don't do it for anyone who has arrested. You need an ECG machine, right? For you to register what type of rhythm it is. If it's a flatline rhythm, you don't need to shock. But if it is a rhythm, which is, very, like something like this, right? Which I've shown you, which is called a ventricular fib, right? A pulseless ventricular fib, right? You need to shock, right? So this is a little advanced, right? This you will only learn it in 4th or 5th year medical school, right? Just remember this. For a person who is having a flatline ECG, like, there is no activity which you all see in movies and all, like, they indirectly show, okay, now he has died, where you see a rhythm and slowly patient is saying his last words, and then in the monitor they show, okay, it's teet, otherwise it's teet, teet, teet. I don't know if you all have watched movies for you all to know, but it's very often where the heart beats teet, teet, they make sounds. And if by any chance there is no rhythm, like teet, it goes on like that, right? So that is basically flatline asystole. But when you look at a person who's having a ventricular fib, it's just it's like, you know, you can see this sort of rhythm. All right. Any questions with regard to this? If you all have not understood, no harm. This is just extra stuff I just felt like telling you all, so that you all know what a defibrillator is, and for you all to know that not everyone who is just on the ground you can actually defibrillate. Okay. Right? And early defibrillation and early advanced care. Right. Next question. What's the next question? Next question is, what is the mnemonic that is used to assess a patient lying unconscious on the ground? Quickly. What is the mnemonic? DRABC. Right. So danger. So make sure that you and your patient is safe. Response. How do you check for response?
Just go and talk
By
to them
talking
and
to the
see.
patient.
Yeah, right. So you go and talk to the patient, see if the patient is talking to you. You know, you don't have to actually go and initially check this thing. If the patient looks completely dead, obviously you need to, you know, start like, are you there? You there? Yahweh is like, okay, is he having anything? No. Is he breathing? It doesn't seem to be breathing. You check for a pulse. If there is no pulse, then you know the patient has arrested. Right. So DRABC. So in this particular place, where does calling for help come?
First,
Very good, right? So it
CPR.
comes to first most important thing. So it's call for help, danger, response. So you can say danger, call for help, response, you have a breathing circulation. Or some people say see for dangers, response, then call for, see if he's if he's talking. If he's talking, you can wait. But see his initial thing and then call for help. So it depends. It depends from person to person. All right. But I always prefer, based on what has happened, I prefer calling for help as soon as possible. How do you check if a patient is responding? Right? We discussed that. How do you assess if the Yahweh is patent? Right. This is checking for response, calling for help. Right. So causes of Yahweh obstruction, there can be the tongue, foreign body, vomitus. What is the maneuver that we do to improve the patency of the Yahweh? Right. What is it called?
Head
Chin,
tilt, chin lift,
head
and jaw.
tilt, chin lift, jaw thrust. Okay. Head tilt, chin lift, jaw thrust. What is head tilt, chin lift, jaw thrust? So you're tilting the head, lifting the chin, right, and thrusting the jaw upwards, right? So from the temporomandibular joint, right, the joint that connects the mandible to the temporal area and the maxilla is actually called, is basically, you have to lift it upwards, like the way, you grinning like this, it actually lifts your this thing. So by doing this, what happens is you increase the diameter of the Yahweh, so that more Yah can actually be delivered. Also, it helps to stabilize the lung. It helps to stabilize the tongue, because one of the common causes of Yahweh obstruction is your own tongue, right? Because when a person is unconscious, the tongue loses its control and it falls back, right? So, and that can cause an obstruction, right? The tongue will actually, which is out here, which now if you can see, right, I'm just going to draw in this, right, the tongue which is like this, right, tongue which is like this loses control and it will fall back. So can you see it? If it falls back, it will completely obstruct this part, right? So when you do a jaw thrust, hold on, when you do a jaw thrust, right, you will push the tongue upwards so that it doesn't fall back, right? That's the reason why you actually do a jaw thrust, right? The jaw thrust, most important reason of a jaw thrust is to help the tongue, to stabilize the tongue, right? Next question is here, as you see, head tilt, chin lift, jaw thrust, another nice image, right? What is the maneuver that you do to improve the patency? We discussed. How do you check for a person breathing? How do you check for a person
Look,
breathing?
listen, feel.
Very good. Look, listen, feel, right? Look for chest. So you keep your head, you turn yourself, and you face your eyes should be looking at the chest. Your cheeks should be feeling the nose, and your ears should be listening for breathing. So look, you're looking for chest movement, right? So out here, right? Yeah. So you're looking for the chest movement, right? You see if the chest is moving up and down, right? You're listening, right? For you're listening for if the patient is actually, breathing, and you're feeling from your cheek. You're feeling if there is air moving out in and out, right? So this is what you need to actually assess. This is the way that you assess if someone is breathing, right? So what's the next one? How do you check for a pulse? Right. So I actually told you what is the common pulse that you check. You check the carotid pulse, right? So the carotid pulse is located on the side of the neck, close to it's between the sternocleidomastoid muscle, right, and the Adam's apple, which is the thyroid cartilage, right? So it's just in between. You always have to use two fingers, not one, two fingers, and you press down and you can feel a pulse. So the common pulse that you always have to check is a carotid pulse because it's a central pulse. What are the other pulses that we discussed you can check? Okay, this is the pulses. So I told you all about the radial pulse, right? The radial pulse, which is out here. Then you have the brachial pulse, right? Brachial pulse. You have the carotid. You have the superficial temporal pulse, right? Which is here, right? Then you have the femoral pulse, right? The popliteal pulse, the posterior tibial pulse, and the dorsalis pedis. You need to know the locations, right? Which I have discussed. I will actually do that during a practical class, right? It's much easier to doing in a practical class because you need to feel it, right? So I will actually get one person who like a guy or someone, and then we'll use him, and we'll actually get when we start practical classes, hopefully, right? Maybe at least once a month we can have a practical class so that you can come over, and we will have all the practical stuff like doing CPR, right? I'll get a mannequin where you can do the CPR. How do you do the chin lift, jaw thrust, and how do you check for things, and I will create a scenario on how you will, as a team, what are the things that you will do. All right, so that is the checking of the pulses. The next one is, what are the pulse? How do you ensure that a good cardiac massage is being followed? How do you ensure?
If the ribs are broken,
Okay, that is not okay. Don't say that as the first thing. Okay, how do you? Don't say that the ribs are broken means you're giving good cardiac massage. That's just, I mean, you can say it as the last point. So the first most important thing is, how do you know that how like in a sense the rate that you're giving the cardiac massage is 100 to 120. The depth should be 5 to 6 centimeters, or one third of the chest, right? The AP diameter, the anterior posterior diameter, it should actually compress. You should be giving enough time for the heart to relax. You can actually make sure that the person, if the person is tired, he needs to change. The person who is giving the CPR should change, right? So these are the things that you can do. You have to do to ensure that there is good good cardiac compressions, right? Otherwise, there are other things, like for example, if the ribs are broken, that means enough force has been given to compress the heart. So these are other things that are there, but don't use that as a first point. Okay, so remember these important things, the rate at which you do it, and all of this, it will make sense when you all are actually doing it. When you all are actually doing CPR on a mannequin, you all will understand of how important this is, right? So the last one is, when do you stop CPR? When do you stop CPR? When the patient starts breathing, when the patient starts talking, someone in emergency medical service or another citizen responder takes over, someone who has enough knowledge about it will say, okay, thank you very much, I'll take over. When an automated external defibrillator is ready to use, okay, which we don't have in our country, right? So that is one. What is an automated external defibrillator? Does anyone know what AED is? Automated external defibrillator. What is an AED? It is called an automated external defibrillator. Remember, you all know what a defibrillator is, no? So that is the thing that you use to shock. So some countries, right, not in Sri Lanka, they have these AEDs placed all over the country. So if by any chance there's an accident, maybe somewhere close to you, maybe there might be an AED, right? So what you need to do if the patient is on the ground, right, you just take that AED machine, take this AED machine, and there will be, it is connected to two pads. You need to keep two pads. So you have to keep one pad here and another pad here, right, which I'm actually, coloring, right? And then in that machine, right, they will record the ECG and say if it needs to be shocked or if the person needs to carry out CPR, right? If the person needs cardiac massage or you need to shock, right? So that is why when you look at the survival chain, you need early access, early CPR, early defibrillation. So quickly recording an ECG will help to decide if the person needs defibrillation or the person needs a cardiac massage, right? So you don't have to be in a hospital. The machine itself will tell you. It will record and say, no, continue CPR. Then it says stop CPR, we will need to shock. And then automatically they will give a shock and then again continue CPR. So that is what an automated external defibrillator is, right? And then when you're doing CPR, it becomes unsafe. If there is a avalanche or something, and then you realize, okay, either it's the patient or yourself, save yourself, right? And you are physically unable to continue, right? So sometimes that. Another thing is, another one who had asked me is like, doctor, how long do you do CPR? Right? There's a very good question. Now someone is there and then still there's no one, and you're doing. How long do you have to wait? Any idea? No one thought about it. Everyone was just listening to me without realizing, okay, how long do you do CPR? Gayatri? Who are the other people who are there? Zahara. These are a few names.
Half an hour.
Half an hour. Okay. Right. It depends. Okay. It depends. So half an hour is okay. 20 minutes actually. 20 to 30 minutes from the point that you do it. Why can't you go more? Can someone answer that? And then we'll start
Because
today's class.
the person will have brain damage because oxygen
Very
does
good.
not reach the brain.
Very good, right? So this is the most important thing. At 4 minutes without oxygen, permanent brain damage sets in. So sometimes when you do CPR for like 1 hour, right, you might be able to recover the patient. You might be able to get the heart to beat. But what you all call in lay terms is like he becomes a vegetable. So when someone becomes a vegetable, he basically does not have any brain activity, right? The brain is completely dead, but the other organs are functioning, right? So then you consider the patient, putting the patient into coma, and then you decide, okay, you need to just euthanize him. You don't have a choice. You just let it go. So there's no point of bringing a person like that back to life if if the person is anyway not going to have a life, right? So that is why the time that they have set is 20 to 30 minutes. Okay, superb. Any questions so far? Shall I continue today's class now?
Yes, doctor.
Yes,
All right,
doctor.
superb. Right, perfect. Let's start, right? And last time we discussed seizures, okay, which I will give you all questions at the end, right? Which we will do later. We spoke about the anatomy of everything, choking, right? Right. So now today we are going to study about bleeding or hemorrhage, right? What is bleeding or hemorrhage? So now you need to know the word hemorrhage, right? Hemorrhage is bleeding, right? So now let's take an example, right? You are in the kitchen, right? Helping your auntie or your mom cut the vegetables, right? And all of a sudden, while your mom or auntie is cutting the onions, she makes a cut like this, right? And she's bleeding. What do you do? So in this instance, what are you going to do? Are you going to call 1990?
No, wash your hand immediately.
Okay, wash your hand. Anything else?
You can
Put
take a
some
cloth and give
surgical
pressure
scripts.
on the wound.
Okay. Okay. So look, one person is saying wash your hands. One person is saying putting surgical spirit. What did you say?
You can take a cloth and give pressure onto the wound to stop the bleeding.
Very good, right? So the most important thing, washing the wound. What is the point of washing?
Okay.
What is the point of washing? The washing is just to make sure that you have just cleaned the area. What is the point of putting the surgical spirit? Again, cleaning that area, right? It's an antiseptic, it will clean that area. But what's the most important thing you need to do in this? The first thing that you think you need to do in this?
Stop the blood.
Stop the bleeding. So how will you stop the bleeding? Like she correctly said, just give direct compression over the wound, right? That's the first thing. You need to give direct compression. Like this person bleeding, just hold. Take something that is sterile, a clean napkin or a clean this thing. Hold on to that area, because holding will what it will do. What can holding do? It will basically help to vasoconstrict whatever that small capillary that has been cut, and automatically it gives time for what? How do you stop bleeding? Tell me, like you all have studied biology. How
It's
does
cover
how how does
bibrinogen. Some proteins cover the solutions.
what proteins cover?
Bibrinogen, prothrombin or something.
Yeah, protrom. Okay, good. That is a different cascade. You're talking about coagulation cascade. That's very good, right? But what is, forget those clotting factors. What is the cell that is in the blood, right? That is responsible for clotting.
Platelets.
Very good, platelets. So what do platelets do? They clump into those areas, right? So the platelets will come into those areas and they will clump and they will form a sort of barrier. If the capillary is being cut from unnamed, it will come and form a fuse so that it stops bleeding. So it needs time. If there is going to be excessive bleeding, the platelets also will come out. But when you give that compression, it gives time and it gives the ability for those platelets to come and make a sort of a platelet plug. Then only, like this young gentleman who said, you have prothrombin, you have these coagulation, it's a coagulation cascade, different clotting factors will come and actually make that clot stronger, right? The platelet plug is not very strong. To strengthen the platelet plug, only you have these clotting factors that will come and this thing. So that is the pathophysiology of how bleeding happens. So that is why it is very important in just giving direct compression, right? Let's just say with direct compression, it did not help. How else can you improve? You keep holding for around 2-3 minutes, still it's bleeding. Is there anything else that you can do?
Tie above the area of the bleed.
Okay, let's not go there. That is last. Okay, let's leave that for now. Anything else apart from that? It's correct. I'm not saying that's wrong. Okay, that is correct, but that is the last step. Before that, is there anything else that you can do?
I think block the
Elevate
bleeding
area.
in the two sides.
Block the bleeding. How do you block? That is by tying something, no?
No. It's
Then how can you block the
something.
bleeding?
Elevate the area.
Very good, right? Elevate the area, right? If you elevate, for example, if you elevate, what's going to happen? The blood has to go against a resistance, right? So the blood flow will reduce. So if the blood flow reduces, again, it increases the chance for the platelets to come and form a platelet plug, right? So you elevate while holding. So you elevate and you give direct compression. So that will again help you. Anything else? If this also fails, one minute. Good morning, Aya. Oh, why? Okay, Aya. Okay, okay. Okay, Aya. Okay, Aya. Okay. Okay. No, I 22nd. Okay. That is a Friday night. No, Aya? Okay. Oh no, yeah, me and Osama figured out a way with on that Saturday Sunday. Yeah, we will, if worst come to us, me and Osama will look after Saturday and Sunday. Yeah, without anyone else. Oh. But if 21st එක රදිකකා කරනවා නම් කරන්න ඕනේ නෑ නේ. Yeah. Okay, yeah. Yeah, she's doing her normal night. Yeah. Okay. Okay, yeah. But then, but why, yeah? We will do it now, yeah. No, we can do it, no issue, no. කරන්න පුළුවන්. But then, යනවනේ 23rd for lies, no, yeah. You just take an off, yeah. Me and Osama will look after. That's what. Yeah. Oh, okay. හරි අයියා. එහෙනම් yeah 22nd morning කරලා දුන්නා නම් කමක් නෑ අයියා. No issue. Okay, right. Okay, no issue. Otherwise, otherwise, I think that week Osama is only going to be there. So, and I was going to come on that Friday and actually do whatever that was there, so that we both will do it. That is what we discussed. Worst come to us, if we are doing an extra night, if you can do any night of any Osamas, I mean, we don't have any problem. Any night. Osamaගේ night එක beforehand and in that weekday මුකුත්වත් අවවෙනවා නා weekday, yeah, before. Okay, right. Okay, take care, yeah, bye. Yeah, so sorry, what is another thing that we can do now if this also doesn't work, if this fails?
Wrap around with a cloth or something to block the blood.
Okay, repair on the cloth. How will you now? Isn't it the same as giving direct compression? The point of you tightening it, the same as giving direct compression. You can again it is in between. Yeah, go on.
After we have to call the doctor.
Okay, you call the doctor. Good, you have called him. He's gonna come. It's still not working, right? He's still on his way and he's bleeding. The patient is bleeding. What else can you do? Is there anything else that you can do?
Hold the hand upside, right? Like
that is what we are doing right now. We have elevated and we are giving direct compression. What's next? The patient is bleeding. There is still blood. What?
So if direct pressure does not work, we apply a tourniquet, right?
Okay. No. Okay. Listen. Let's keep tourniquet last. Let's say there's something else. Tell me. Start thinking. What else can we do? And you don't need anything fancy. Everything is available at home. Think about thermoregulation.
thermoregulation.
What? Go on.
Can you keep ice on it? Like something
very
liquid?
Good. Right. What's the next one? You can actually put ice. Right? What's the material of it? What will ice do?
It's freeze the blood.
What is the word? Doesn't freeze the blood. What is the word that I'm looking for? Well, I've studied this. Y'all should know. What happens to the capillaries when you keep
vasoconstriction?
Very good. It causes vasoconstriction. What is vasoconstriction? It constricts. It basically narrows down those capillaries. So very little blood will actually come there. So the bleeding will automatically stop. Okay. So this is again, why am I telling you what is the point? What does it do? Because I want you all to understand the importance of everything that we are doing. Right? Api nikan karanne. We are not doing anything just like that. Okay, here you do this, you do that. No. Try to understand by doing this what exactly is happening. So now you know when someone is bleeding, the whole point is you need to give time for your body to actually stop, put a permanent platelet plug. How can you help your body? So the first one was you give direct compression. By giving direct compression, it gives the ability for the platelets to actually come in, because there is not a lot of excessive bleeding. You have stopped it. So, you know, it can slowly come in and it can form a platelet plug. If that doesn't help, you raise it, you elevate it so that the blood flow is minimized because of the gravity. Number two, still if it is bleeding, you put ice around, or, you know, in that area. What is it going to do? It's going to even narrow down the blood, the blood vessel. So therefore, the amount of blood flow coming will reduce, and therefore it will give more time for the platelet to aggregate. Understood? I want you all to understand the principles. And then when you understand the principles, it will be very easy for you to actually, you know, treat patients. Okay. Now,
if he
yes,
has
yeah.
a leukemia, is it helpful for that?
What does he have if he has a
Leukemia?
leukemia?
Yeah,
What do you mean by
leukemia. Leukemia. Like
leukemia?
the,
Okay, he has leukemia. Okay, now
it's
if
in
a person,
Tamil leukemia, right?
yeah, if a person who is having leukemia, right, actually starts bleeding, right, it is absolutely essential. A small bleed like this, right? Now, initially I asked you all whether this person needs to actually, you need to call for help, right? But if a person like who is having low blood because of leukemia, his hemoglobin or her hemoglobin is low, and if a person is bleeding like this itself can be life threatening. So for a person like this, you can do all of these things, and you need to quickly go to the hospital and check how much of blood that she's lost. Simple, right? If you have managed to control the bleeding as soon as possible, then you don't have to worry. But if a person who is having a lot of bleeding, yes. And anyway, this wound is big, the wound is deep, it will definitely need suture. So you need to go and see a doctor anyway, right? So there is no other issue. But the problem is a person, now this question is, now with a person who's having leukemia will affect all the cell lines. It will affect the hemoglobin, it will affect the WBCs, it will also affect what? It will affect the platelets. So sometimes there is a possibility that by, you know, doing all of these three things, it might take more time for the platelets to aggregate and form a platelet plug, right? So it's a very complicated situation. Don't try to think about it too much. But in that instance also, you can try all of these things. And definitely all of y'all can try this. Y'all don't need anything at home. Just basic principles, and that is absolutely more than enough. Right? So for this patient, what we did was we managed to arrest the area. Arrest the bleeding. Right? We stopped the hemorrhage. Right? And it stopped. Then later, after we stopped the bleeding, we wash that area on running water. Very important. You need to wash wounds on running water, right? When there's a running, you can't just put water. You need to run the water on top so that it flows down, right? It keeps flowing down. Whatever dirt that is there, that flows down. You can't just put the water, because what it does then is then it actually causes some of the dirts to go in, right? By running water, what it does is it helps to actually take whatever dirt, whatever was on that knife before, like for example, onion peels or fragments of these onion peels, to actually, leave the wound area. Okay, right. So after you have washed the wound in running water, what's next? You apply an antiseptic solution, right? So it can either be Dettol or it can be Betadine, whatever is available at home, right? And then you close that wound and you bring that person to the hospital, and we will, suture it. So these are all real pictures of when I had a patient who had a cut injury, and where we, after they brought him, we cleaned the wound. If there was no big bleeding sites, right? If there was nothing to ligate, sometimes this is all when I'm talking about capillary bleeding. Sometimes there can be venous bleeding, arterial bleeding. So then by doing all these maneuvers, it won't help. That's the next scenario I will talk about, right? Now you have something like this, a deep wound, right? And it's bleeding excessively, right? So how do you decide if this bleeding is arterial bleeding, venous bleeding, or capillary bleeding, right? So, when you have slow, even flow bleeding, then it is capillary bleeding. If there is steady, slow flow, dark red color bleeding, it is venous bleeding. So remember, right? Remember very importantly, if you doing this, you basically putting direct compression, you raising, you elevating, you putting an ice, and it settles, that means the bleeding is either capillary or venous. But if the bleeding is spurting blood, there is a pulsating blood flow, and there is bright red color blood, how much even you do that, the bleeding is not going to stop. Arterial bleeding will never stop. You need to quickly tighten that area. Sometimes, it will be so extreme that you might have to do the turn. You will have to actually use a tourniquet, right? So that is where, okay, right. So I will talk about the tourniquet, but now this is where I wanted to talk about the pulses that are there. Now, why I want you all to see the pulses, right? So let me just draw and show you the importance, right? Okay. Now, let's just say this person has a cut somewhere here. He's got a deep cut here. Can you see in the slide? Can you all of y'all see?
Yeah.
Yes, doctor.
So if he's got a cut here and he's spurting blood, he's like bleeding, bleeding, bleeding. What do you think? Which artery do you think might be cut? Now, if it looks like it is an arterial bleed, right? It looks like an arterial bleed because he's spurting blood. It is fresh, bright color. You've tried everything and still it's bleeding. You've tried to elevate. How do you know? Like in a sense, now you know. Okay, maybe this is an arterial bleed. So, what is the artery that has actually? How can you confirm if it is an arterial bleed or not? I want a logical answer.
Flow is higher. It's
Now, for example, if there is a cut in this artery out here, right? What's going to happen here? No blood is going to leave because obviously the blood is going out from here. Correct? Agree? Everyone tell me agree or not? Okay. If there's a cut here in an artery, the blood is going to go out. Correct?
Yes, doctor.
Yes,
Yes,
doctor.
Can it go back again here? Very, very unlikely. No, can it go? No, no way.
No.
So if there is, for example, if there is like a finger or something here, the fingertip, what's going to happen? The finger is not going to get blood. Agree?
yes.
yeah.
Yes.
Yeah. So now, for example, somewhere here, right? And if the area is cut here, now for example, the area here, just imagine this is, I have zoomed and taken it. It's cut here, and this is the area. This is in the hand, right? This is in the hand, right? Can you feel the radial pulse?
No.
No, doctor.
No, doctor.
Exactly. If you feel the distal radial pulse, I mean distal pulse, if it's absent, it means the cut is in that artery. You understand, right? So if the distal pulse is absent, right, the pulse that is distal to the wound, distal can be if it's away. Distal is away. Remember, distal is away. Proximal is before. Proximal and distal. You need to know these two words. Proximal and distal. Very common nomenclature that is used in anatomy. When it's what is proximal? Proximal is this. Distal is this. Okay, you should know this, right? So any pulse, I mean any pulse distal to the wound. So this is away. Distal to the wound, right? If it's absent, that means there is a high possibility that artery has been cut. Right? So luckily, why the hand won't have a problem? Now, if the radial artery is cut like this, why will the hand not have an issue? I mean, why will the hand not become blue? Why will it not become cyanosed? Otherwise, if now technically what you said, if this radial artery was completely cut, no blood is leaving, no blood is going into the hand. So how is the hand getting its oxygen and all the nutrients? Why? Look at. I have the hint is already there in the picture that I've drawn.
There are other arteries that bring blood.
Very good. So there is an ulnar artery. There is another ulnar artery that is also going in that same pathway, right? So that is why there are two arteries and they will anastomose. What is anastomose? They will connect together. Can you see? They are connecting. So just because the blood is, so because the blood is not actually getting here, so the cells out here, how will it get the blood? Blood from the ulnar. This is the radial artery, right? This is R. This is ulnar artery, right? So blood will go like this, like this, like this pathway. This pathway is pathway, and then because there is no blood coming here, there is no pressure, the blood can go here. And then it can bleed from here also. And then it will go to these parts as well. You understand? So that's the beauty of the human body. We have all these compensatory things, right? So that is how you will assess. Now imagine a
Doctor,
scenario.
doctor, I
Yes,
have a doubt.
yes, go on.
What if the cut is on the wrist?
Okay, very good. This is what I was wanted to know, right? So if that was what I was going to continue. I like the fact that you thought about it, right? Now, for example, let's take the same thing, right? If by any chance you have a patient who is having a cut in the wrist, right? Let's draw it. So for example, right. So he's got something now. This is the radial artery where we actually feel it. This is the ulnar artery, right? That is coming and then it's forming a circle of this thing. Then it's going the digital arteries and all that, right? So if the patient is having a cut somewhere here, that is what you mean, right? Correct? Am I right?
Yes, doctor.
Okay, right. How will you check? Now the patient is bleeding, like sprouting blood, spurting blood, right? It's fresh red, and you're suspecting it is an arterial bleed. How will you check? That is why you check for something called capillary refilling time, right? So you take the nails, right? And you actually press on your nails, right? You press on your nails, you will see, you all can do it, right? I will show you all during the practical classes how it is properly done. You will see it becomes white, it becomes, it blanches. We use the word blanches. It becomes very whitish and you press for 2 seconds and then you release. And it should become red or it should become rosy or it should become pinkish less than 2 seconds. Normally it should be less than 2 seconds. But if it is prolonged, it is taking time for for it to become pink, then we say the capillary refilling time is prolonged. Normally it should be less than 2 seconds. If it's more than 2 seconds, it is prolonged. It means that there is a deficit of the blood that is actually coming into the distal fingers. But again, you don't have to worry, because if both arteries are cut only, you will have a compromise. If both arteries, that is ulnar and the radial distal to this areas, if both of them are cut, then only there will be CRFT more than 2 seconds. That is, the capillary refilling time will be more than 2 seconds. Understand, right? So you need to actually, I mean, we look at it. That is why these things we call anastomosis, right? So usually the human body has a lot of places that is like that. I will talk to you about another example later on, where a person had a fracture of the scapula, right? And there is an artery. It cut off the big artery, right? I remember he had a scapular fracture, right? Now, you know where the scapula is? No, what is the scapula bone? What is it also called? By drawing the verse. That is why I'm just, right? So the scapular bone is over here, right? Is the shoulder, in the shoulder girdle, right? The scapular bone. So it had cut. It was a bad fracture, and the bone fragment had damaged the subclavian artery, right? So it had damaged the subclavian artery. So I'm gonna zoom this. Okay, I'm gonna zoom the arterial this thing. So it had damaged the subclavian artery. And this is the brachial artery, right, which goes into the hand, right? This is the brachial artery. Brachial, this is the subclavian. So it had damaged the subclavian artery somewhere here, and there was a huge bruise mark, a contusion in this thing. But when I checked the distal pulse, it was normal, right? But the patient was complaining of pain, severe pain. When we did an X-ray, right? So because the distal pulses were there, both, I mean, the radial distal pulses there, I wasn't worried. We did not know that he had completely cut off the subclavian artery territory. We did not think of it at all. But when we did an X-ray, the fracture was so bad where you can see it had moved up. And myself was a little confused. And that is why he did a CT scan, right? And when we did a CT scan, we saw that there was a huge this thing, and we had to take him straight to the surgery and repair it. But my question was, why was there a distal pulse? If it was completely cut here, and it is, the brachial artery that goes all the way down, why did we still feel a pulse? Any ideas? I just think about it. Just tell me, if it is completely cut here, right? And this is that same artery that is going down all the way, right? Why was it that I still felt for a pulse? Tell me. Anyone? If someone can answer this question, right, I will definitely give y'all a chocolate the next time I see y'all for practical classes. Think a bit and tell me, how was it that there was still a pulse, there was still a radial pulse when the main artery was cut? Anyone wants to try? Everyone's given up? Shall I tell the answer, or should I
So
wait?
maybe because of internal bleeding.
Okay, if there was internal bleeding, then how? But then how did I feel a pulse? There was internal bleeding only. There was no wound on the outside. Okay, this scenario, you can't see. He's not bleeding from the outside. I didn't even think that there is the possibility. He was complaining of shoulder pain. I was like, okay, it can be a fracture. But I had checked for his radial pulse, and his radial pulse was there. So I was like, if the radial pulse is there, that means that the blood has to flow all the way from the heart, from the subclavian artery to the brachial artery, right, to the ulnar and the radial artery, and for me to feel a pulse. So if that means the blood flow is good, I don't have to worry. I don't have to worry whether there is any vascular damage. I did not worry about it at all. But when we did an X-ray where we saw the scapula had been completely, shattered, and it was pressing on the area where the subclavian artery is, and the CT confirmed it, I was a little confused as to why there was still a pulse. Because the pulse being there shows that there is no vascular damage. But when we did a CT scan, there is vascular damage. Why is that? No one wants to try even again? Anyone? I don't want you all to know it concretely, but just tell me what can be the possibility. I'll wait for another 30 seconds. Anyone who wants to try? No one wants to try for a chocolate? Okay, I'll make it 2 chocolates. Still no? All right, let me tell the answer, right? That's because now this area was cut here, right? There is an artery that runs from here and joins the brachial artery here. So even though the person was bleeding from here, there was blood that was leaving like this and going to these areas. Just like that ulnar artery, there is a circumflex artery that goes from the subclavian that connects the brachial artery. So because of that, because there was blood flow through an anastomosis, these are called anastomosis, between the subclavian artery and the brachial artery, the normal anastomosis, that made me think that there was no vascular damage. Any questions? Did you all understand this?
So doctor, so do we like always have to take a CT scan to confirm
No,
anything?
it's not. Kid, it's not. But these are all like rare, complicated cases. You won't get this. If you have around 200, 300 cases, this you will say 1 is to around 300 or even more. 1 is to around 500. You see 500 cases, one case like that you will get. So it's very, very unlikely. You will not get these things. You don't have to do CT scans just like that. But these are just a few things that you might think of, that is why medicine is very interesting. It's very complicated sometimes, and it just puts you on the edge. It's always, it's like a puzzle. You need to figure out if there is something like that, it doesn't make sense. You need to look into these things, right? So routinely you don't have to, but if there is anything that is alarming you, where you think, okay, there can be something more, yeah, then yes, you might need a CT scan, right? Now, to understand this particular thing better, right? If you look into a house that is getting water supply from somewhere, right? If you are getting water supply from these pipes, right? And if the pipe is completely broken, what do some people do? Our neighboring house king, they try to connect this so that they are getting the water supply from here. Even though this is broken, they are getting it from here, right? So the water supply for them also is coming. So you make a connection like this. So this is called an anastomosis. But luckily in our human body, we have already anastomosis that are there. We don't have to go and make another one. This is the same principle. This same principle is used for what? For cardiac bypass, right? For heart problems, when the heart is there, right? If the coronary artery is blocked, right? When the coronary artery is blocked, right? So, and if this is the other areas that need the blood, this area is completely blocked. What do? We can't actually, clear that area. So we take an artery and we connect it. We take a graft and we connect between two different arteries. So blood can go like this way. That is the principle of even cardiac bypass, right? So these are principles that with these ideologies, with these principles, we have different ways of treating patients also. Okay, right? Any questions so far? Right, so this wound also, now let's just say that forget all of this, and now we'll talk about what y'all were always saying, using a tourniquet. If he's having extreme bleeding and you don't think by any way you can stop this bleeding, yes, then you have to apply tourniquet. But there are principles of you applying a tourniquet. You need to make sure that it should be as close as possible to the wound. If the wound is here, you need to make sure it's as close as possible, because what happens when you do that? Now let's just imagine the same principle. See, hold on. The same principle where the person was having a cut in the radial artery, let's just say, right? He was having a cut in the radial artery, right? And if you use a tourniquet, what happens? Tell me. No, now this will give you an idea as to why I'm saying tourniquet should be the last resort. Why am I, emphasizing tourniquet should be the last resort, right? Where is this? Where is my slide? Yeah, now the person is having a cut here. Right? Now if the person is having a cut here, and you have tried everything, it's hurting, and now you're going to put a tourniquet, right? You check the radial pulse was not there, right? Now you apply the tourniquet as close as possible to the wound. What is the problem with this when you do this? Why am I saying use this as a last resort? Don't use it at the initial point. Why?
Because it stops the blood loss by stopping the blood flow. And in the
Very
long run,
good.
it actually leads to the death of the cells in the hand. Like it's
Very,
not always
very
possible,
good.
but it's one of the chances of happening.
Yes, it
And
doesn't
then the
always.
potassium
Very
buildup.
good. Yeah, very good. That's good. So now, if like the way I said, now here, if the radial artery is cut, the ulnar artery is normal. That is what is providing the blood flow to the hand. So by putting a tourniquet, you're not just stopping the radial artery, you're not compressing the radial artery, but you're also compressing the good ulnar artery. You understand? So because of that reason, you are going to compromise this blood flow to the hand. So this hand can go into cyanosis. What is cyanosis? It turning blue. And then this cyanosis can turn into death, which is called necrosis. Okay. These are words which I will emphasize again. Cyanosis is when something gets blue, right? The hand gets blue because it's not getting oxygen. Death, basically death, when it becomes black, you call it necrosis, right? So it is a big compromise, and I don't want everyone to take it only in a condition where you think him bleeding is going to kill him. Then worrying about his leg, you have to use a tourniquet. So this is usually done during, when in war situations and all, where they think, okay, it's better to just sacrifice the leg and save the person's life, right? So that is why applying a tourniquet is a little dangerous. Now you can see he has put it. So there are some principles where you have the two. If you have a cut here, because both arteries are cut, you actually, this is the brachial artery, you do it, but you have to make sure that you have to apply it for the shortest possible time, right? For a healthy person, safe limit of time is 1 hour. You apply it for 1 hour maximum for a difficult operation. Now this is another thing. Because of these scenarios, we use these kind of things for surgeries. Now, does anyone know what carpal tunnel syndrome is? Has anyone had a surgery called carpal tunnel syndrome? No, like a tingling sensation, right? So not even carpal tunnel syndrome. So now when I was doing my surgical appointment, right? Right? We had instances where we had to do a surgery, like for example, right? If this is the hand, right? Sometimes there's this carpal tunnel where you have to, do a surgery and you have to make a cut like this in the hand and you have to observe, right? So sometimes if the person is going to bleed unnecessarily, it's going to be a problem. So what we do is we apply a tourniquet. We apply a tourniquet here. So before the surgery, right, we apply a tourniquet. When you apply the tourniquet, you know that there is not going to be bleeding from here, right? You're not going to be bleeding. So you quickly do the operation, right? You do everything because it's a bloodless field. It's known as a bloodless field or an avascular field. So there's not going to be any bleeding. You can do the operation without any problem. You can see a lot of things because there's not going to be unnecessary bleeding. And as soon as the surgery is done, you remove the tourniquet. So you can keep it to one to 1.5 hours or 2 hours. It all depends on the patient. But when it's a trauma, you can keep it maximum for 1 hour. Right? So this is the drawbacks. If you keep it for more than 1 hour, it can be a problem. Right? And also if by any chance you have to transport a patient far away, and it will take around 2-3 hours. So what you do is you keep it for 45 minutes, release, and let a little bit of blood flow back. Again, you press it. That is, you tighten it with a tourniquet. That's how you normally do it. Any questions? Right? So this same thing where we had sutured. Scalp also the same thing, right? Scalp bleeding. This is in the head. I had a patient who had actually had this was because he got into a brawl and then a person had used a knife and tried to hit his skull, right? So you can see that you can see there is an area where you can see the bone, that is the skull. There is an aponeurosis, very thin aponeurosis on the head and the skin. So we had managed to suture, right, and that automatically stopped the bleeding. Again, same principles you can apply. You can give direct compression, right? You can apply ice on that area. Obviously you can't put a tourniquet here. You don't need to. Usually scalp wounds don't bleed that much because they don't have arteries that are going all over. It's just these small capillary bleeds that you find. Sometimes they can bleed a lot, but usually when you suture it, it becomes all right. So you bring those patients as quickly as possible to the hospital. Deep bleeds like this with a muscle bleeds also can be easily repaired. This is the one that you were talking about, maybe close to the wrist joint, where you don't know if there is any arterial bleeds because there is no arteries, there is no pulses that you can actually check, but you can check for the capillary refilling time, right? And see if there is enough blood flow that is going around. And if you can actually stop the bleeding by, doing all those principles, superb. That means that, okay, there is nothing much to worry about. But if he's bleeding a lot, you quickly, put a bandage, a tight bandage or whatever, and bring him to the hospital as soon as possible. So this patient also had actually a cut while he was actually trying to put a hook into some fishing rod, and it had pierced his hand. It was a deep cut that extended from the wrist joint to the second metacarpal area, right? And we had to suture the muscles inside as well as the tendons and then the skin, right? Now, this is the last thing that I'm going to be discussing today, right? What if you are in an instance where someone has got into a physical fight and you have a complete amputation of the distal side? What would you do? So this was actually in Balapitiya when I was a surgical resident there, and there had been a major quarrel between two fishmongers, and one of them had taken a katiak and completely chopped off the hand. Right. So what do you do? How do you bring this to the hospital as soon as possible? So there is one area which is bleeding like this, the other area which is like this. What can you do? What are the principles that you can take? So for here, do you think that you need to actually put a tourniquet? What do you guys think? Tourniquet is
Yes.
necessary? Yes, very important. Tourniquet is definitely necessary, right? So this is the hand that was there, right? So what is the principle? You need to put, now a lot of people say you need to put it in ice, right? A lot of people make the mistake in putting this directly in ice. Wrong. You find a bag, a silly bag or a zipper bag. You put that component in this bag and that bag into a bag which has a lot of ice. So there, if there is water contamination, on this, it will be difficult. It will infect this area. Therefore, you put this in a zipper bag or a siri bag or some bag and put that bag into an ice bag and bring the patient as soon as possible. Right. Luckily, this patient we actually did the initial things and we transferred the patient to Karapiti, the vascular unit, where they repaired the blood vessels, the arteries, the radial artery, the ulnar artery. They fixed the two bones together. They fixed all the muscles and the tendons, and they sutured everything up. And they put him on a plate. I remember he came back again and he had a completely functioning hand. Right. So this is just the principles of what you do when you have a complete amputated hand. Right. Any questions? I'm done. Next time we will be discussing burns. Any questions so far?
Yes. At what point have you ever cauterized the artery or vein or something like that? Like where you cauterize something?
Okay, you're talking about cauterization. Does everyone know what cauterization is? What is cauterization? Why don't you tell everyone what cauterization is?
It's basically a technique of where you burn a particular thing to stop the bleeding.
Exactly. So this is how this is in surgery. In surgeries, when we do, right, we sometimes actually, cauterize, right? So yeah, sometimes you can, right? You basically, you cauterize because you give heat and you clot that area. You make now, for example, if there is give me a minute, if there is an artery, like this, and if it's cut, right, you can hold this area and you can cauterize it. What will do, it will seal this off. So while we do surgeries and all, we sometimes use this cauterization technique. But for patients who have trauma, we don't use cauterization because we don't know how much of other vessels can get damaged, right? So if it is a elective surgery, right, it's a routine surgery you're going and doing, yes, you will use electrocauterization to make sure that, you minimize the bleeding. So that whatever small blood vessels are there, you will actually, just cauterize it. So it is a principle that can be used. There is no harm in not using it. In the hospital setup, you can, but we prefer using now if there is a big bleed in the hand, and then in the hand, right, and the patient is bleeding a lot. So there are two things that I can do. I can actually cauterize it, or I can tie it. I can actually put a particular suture, and I can tie this, or I can cauterize it. Anything that you can do. But if you can repair it, best is to repair. But if you can't repair, then you have to tie these two distal and proximal ends. Any questions?
Thanks, doctor.
No. All right. Super. Right. Basically, we were not supposed to have this class, but I had it because I felt like, because I think at IMC they have holidays and they will resume only from the next week. but I wanted to have this class, but I don't feel it's right for me to give you all homework, right? So I'll give you all homework next week, right? I hope you enjoyed this class. Please let me know with regard to the feedback of this portal and whether you all enjoy these classes, or if there is anything that you feel that we should improve on or whatever. Please let me know. Please let the counselors know. And with especially with regard to MS Teams, if you all find it difficult with Teams, or you all prefer Zoom because of some things that are difficult with this portal, let me know and we will try to figure it out. Okay. Thank you very, very much. Have an amazing day. If you all have any questions, I can answer. We have time. But if you all don't have any questions, I think that is a wrap. I'm assuming there are no questions. So take care. Bye. God bless you all.
Bye.
Thank you.
Thank you, doctor.
Thank you, doctor.
Thank you, doctor.
Thank you, doctor. Thank you, doctor.
Thank you, doctor.